So let's come to the next topic, which is Fibular Hemimellia, and you already heard a little bit about it. So let's start this. So Fibular Hemimellia is the second of like the big three. As I said before, it's very commonly combined with CFD, and again we have a very wide involvement and the complex anatomy. We always see a leg length discrepancy, of course. We have a foot and ankle deformity, a tibial deformity, which is quite complex, with a procovatum, but also a distal tibial deformity sometimes. We have, again, a valgum deformity, knee instability, and a lateral rate deficiency. And this lateral rate deficiency is really like the first sign that you sometimes see. So whenever you only see 4 toes, something's very wrong, and something points towards a fibular hemimellia. This is the old classification. You saw the Achtermann and Kalamchi, which basically just differentiates between a lot of fibula, a little bit of fibula, and no fibula. Of course, this is very descriptive and not very helpful in regards to treatment. So Dror Paley, he introduced his classification, which mostly or solely looks at the ankle joint. And this has a very good reason, because the ankle joint is the biggest problem in fibular hemimellia and is really the most difficult to reconstruct. And we have basically 4 big types, which is the stable ankle joint. We have a valgus deformity of the foot, a equinovalgus deformity, and a clubfoot type. And of course, there is a differentiation if the valgus is just in the foot or if it's a distal ankle deformity. Now, again, we have a lot of associated problems. We have on the knee joint cruciate ligament hypoplasia, aplasia, we have a procovatum, we have at the distal tibia a valgus joint line, and so also some procovatum at the distal tibia. And at the hindfoot, we have a valgus. Many times we have coalition. We also have coalition in the midfoot. We have the missing race, and we have a contracture of the Achilles tendon, and in many cases, so also of the peroneal tendons. But you will see there are many different kind of deformities. So some, like the 3A, have primarily a lot of equinus, not so much valgus, and you can see the foot looks a little bit more normal in compared to, for example, this foot. But here you can also appreciate, look at the knee joint. So no treatment so far, and already you can see quite an instability, and you can see how the tibia is a little bit subluxated to anterior. Now in this case, you can see 4 rays. So like regarding to some people, they would say, oh, it's 4 rays. That's a very easy to reconstruct case. But I'm not so sure if you look at the foot and if you look at the ankle. This is quite a difficult foot deformity. This is the talus, this is the calcaneus, this is the so-called double barrel position of the foot, and this is not so easy to reconstruct, in fact. Again, this is a 3C, and here you also see one of the things that is very pathognomic for a fibular hemimellia, and this is this procovatum and this dimple here. So many cases that are more severe, they have the small skin dimple. This is also a telltale sign for fib hemi, and of course, a 3-ray foot in this case. The other thing you can appreciate, there is this procovatum deformity, but also a very severe equinus deformity of the hindfoot. And it's not only equinus, it seems that the calcaneus is besides the tibia. The talus, you can see this small piece here, this is most likely the talar Anlage. And if you see that they're very close together, this also tells you that most of the times they are fused. This is a very, very severe case. So you see that there is a very big range. And this is a very strange case. You can see only a 2-ray foot. And if you look at the MRI, you can see that this calcaneus here with multiple small nuclei or civic nuclei really goes up into the calf muscle here and is a really complex deformity with a lot of procovatum in the midfoot. And on the left side, you can see a clubfoot type fibular hemimellia. And again, if you have the bones so close together, this tells you that most likely you will find a coalition between all these 3 bones at that early stage, which is quite unusual because many of these clubfoot type fib hemis, they are quite flexible in the first month of life. Now, what do we have to deal with? We have to deal with the fibular Anlage, and that's very interesting. We did a study and we found that, of course, the recurrence is mostly from the distal femur, so that's something we found when we looked at the knee joints, as you remember, from the morning. But there is a recurrence, and this is depending, of course, on the severity of CFD and fib hemi, a little bit on the ball and socket joint configuration, so you get some valgus from joint line incongruency, but also resecting the fibular Anlage reduces the rate of recurrence significantly. And this is something we know today. Whenever we do a case, we need to resect the fibular Anlage. Of course, there were different approaches throughout the years. For some time, we thought we need to get the whole thing, and we did a big lateral approach and resected the whole fibular Anlage. Now, today, sometimes in severe cases with a lot of valgus, we come from a medial approach and come from the medial side to the fibular Anlage, which sounds strange, but the fibular Anlage is so posterior in regards to the tibia that you can still resect it from a medial approach. So, regarding the treatment algorithm for fib hemi, again, it's dependent, of course, at the leg length discrepancy at maturity. We want to match up the leg lengthening during growth. So usually we do the first lengthening when the discrepancy is 4 to 5 centimeters. We need to correct the recurrent valgus, and we use guided growth for that. And we need to correct the ankle pathology. And this depends. We can do it initially, and we include a very mild lengthening. And again, of course, a hemiepiphysiodesis is also, the epiphysiodesis of the contralateral side is also something to consider. So let's go back to this case. This is a type 3A, and you can see a lot of equinas in this case, but a quite good foot. And so for this case, what we did is a resection of the fibular Anlage, nerve release, and then we did what was very nicely described by Drew Paley in this paper from Journal of Children's Orthopedics from 2016, which is this approach where you do a shortening and like an angulation. Before that, it was usually done was the lateral opening wedge, so of the distal tibia, which worked very nicely too. But the problem was you create more of a skin problem because it's already tight, and now you even bring in a wedge, which makes the skin even more problematic. And then you also want to bring down the heel out of valgus, which makes the skin even more problematic. So this is a nice approach that allows you to relax your soft tissues, not only skin, but also your tendons, and gives you a good correction. You overcorrect a little bit. Of course, you need to be aware if you overcorrect a little bit, it will remodel with growth. And the other thing you can correct with this supramalleolar osteotomy is the pathologic procovatum at the joint line level. So if you measure the 8DTA there, in many cases you will see that there is some procovatum at the joint line, and this is also something you can correct. At the same time, if you have fusion of the subtalar joint in valgus deformity, you can do an osteotomy and correct this and fix all this within the frame. So this is what I did for this girl at the age of 20 months. You can see the resection with a wedge, so correcting some of the valgus, but also a little bit of the procovatum. And actually, she had a flexible subtalar joint. So in this case, of course, you can't do a corrective osteotomy. So I felt for it. It was flexible. So we left it like this. Sometimes, if you really want to know if there is emotion or not, you need to transfix the talus because of the instability in the ankle joint. Of course, you can always bring the foot in a nice position, but as soon as you remove the K-wire, it just comes back. So always make sure that so also if you do the osteotomy, you need to transfix the talus to make sure that you really correct the deformity and not just bend it in the ankle joint. So part of this is you do all this work like on the foot and on the ankle joint, and then you come back and you bring on a frame. And you still do an osteotomy for a mild lengthening. And if you look at this, it can become a little bit crowded. Yeah? So it's not so easy to get all your fixation in here. But it's a very, so in the end, it's a very small frame. And you can see that this K-wire still fixes that this K-wire is still above the ankle joint, and this half pin is above the supramalleolar osteotomy. This was during lengthening, and actually those patients, they are very mobile with this. They get a small walking platform, and they walk around quite happily. We also have a psychological service that prepares the patients to be to look for any problems that might come from that direction. So the time in frame in cases like this is very short because they are so young that, like in this case, the time in frame was only 3 months, so you can remove the frame very early and you can put on a cast. The problem sometimes is, I think, because the time in frame is so short that there's still quite a lot of tension in the soft tissue, so you need to be careful. So now I rather like to leave them for a little bit longer in the frame, maybe like 4 months, because you don't want to have a recurrence of your corrected equinus and your corrected valgus by still having quite a lot of tension within your soft tissues here. Now there's another case which was a little bit like this, but now in this case, now 3C, you can see that there is a fusion between the talus and the calcaneus. So this one included subtalar osteotomy, but same principles. You can see lengthening between these two half pins, and again, usually only lengthen about 3 to 4 centimeters. This is just you want to gain a little bit of length, and you want to give back what you resected distally and add some centimeters here. So patients walk very nicely with this walking platform, as you can see, and we had a quite good correction in this case. Nevertheless, you think you correct the foot quite nicely, but sometimes they also have a little bit of a recurrence. And this is a problem, so also they sometimes have some recurrence of this valgus deformity. And of course, you can see at the knee joint there is some instability at the knee, so she will need most likely a super knee procedure somewhere down the road. The next step here for us was to do a lengthening and a correction of, she had just quite some retroversion of the retroversion on the femur, at the same time with a bridging of the knee joint. And then a couple of years later, we did another lengthening, femur and tibia at that time. And again, you can see this fixation of the tibia with the rush pin to prevent refracture. She sustained quite stable at the knee joint, so far we did not have to do a super knee. Now that's what we usually do. We like to address the ankle joint first, but sometimes patients come late, and now in this case the patient came with a very big leg length discrepancy already, so she had like initially orthotic treatment. She only presented to me at the age of 5 years, and the leg length discrepancy was already like 11 centimeters and predicted 16 centimeters. Now in that case, the question is, do you look at the ankle immediately? Do you do the ankle first, or do you lengthen first? And my approach in this case was to first gain some length, because not to fall that much behind. And you can see our technique again with the TSF on the femur, flexible bridging of the knee joint, and lengthening of the tibia. This was done in November of 2014. And you can see I lengthened 5 centimeters on the tibia, 3 centimeters on the femur, for a total of 8 centimeter lengthening. And this was the frame. I agree that's a pretty big frame, but the advantage is you can put on this walking platform to compensate for the leg length discrepancy. She had a flexible bridging of the knee joint and was able to flex her knee and to work on her knee. And you've seen this before. I always try to get in this rush pin because in the fibula it's much easier, because you can put on a cast if you're not so super happy with the fibula, but you can't put on a cast on the femur. So the rush pin is a nice idea. Looked very nice. She presented with some valgus deformity, with some recurrence of the valgus down the road. She had some guided growth for this. But then, of course, looks very nice. She was quite happy because the first time she was able to walk with shoes. But, of course, if we look at the foot, this is quite a disaster. Severe valgus deformity on the foot. You can see talus and calcaneus are standing next to each other. And she already had, again, a Lagrange discrepancy of 4 centimeters. So at that point, I decided to do both. You can see the valgus here, you can see the extreme flat foot position. Correct first the foot, and then do the lengthening at the same time. And here you can see the principle. You remove a wedge, which is a medial-based wedge. It's an anterior-based wedge. You correct the deformity. Then you need to transfix the talus, at least temporarily, if you want to do your osteotomy and to correct the hindfoot. Sometimes for long-standing foot deformities, it's not so easy, because if you do correct the hindfoot completely, you turn up your forefoot, midfoot quite a bit, and then there's a lot of supination. So sometimes in the end you go for something in between, where you think they have a good alignment, the heel is well under the tibia, but of course they might still be in a little bit of valgus. So, but this was the position at the end, so this looks quite nice with the calcaneus quite underneath. And so here just 3 half pins, no K-wires in the proximal tibia, so range of motion exercises are very easy. This was her frame, and she had a very nice 5 centimeter lengthening. Time in frame was only 4.5 months, so she was walking a lot, she was very active with this frame, and we were able to remove it quite early. The foot looked much better, and it's still not a normal foot, but it's stable, and it's very stable underneath the tibia. And now I also did a rodding for the tibia to prevent fracture. She's now 13 years old, 14 years old, so this was in 2001. And she's predicted to have a 2.6 centimeter Lagrange discrepancy at the end of growth, so she will get a final pre-size on the tibia, most likely beginning of next year. We talked about the clubfoot type, and I think the clubfoot type is a very interesting one, because some of those you think, and they do turn into a coalition, but some of those are still quite flexible in the first month. And there's also a paper on this actually from Oliver Eberhard from Germany. I think unfortunately it's in German literature, but he showed that you can use the Fonsetti method to correct clubfoot in fibular hemimellia. Again, at the beginning, some of those, not all of those, if you remember the first one I showed you, but some of those, they are not fused yet, so you can still form them. And like in this case, this was after casting, and you can see that you can correct a clubfoot type foot with casting. Nevertheless, they do, with time, they do form this coalition, and this looks a lot like the case Mark showed us. So this is very much the same situation, and it is a quite difficult one, because when they get a little bit older, they get more problems. We'll come to this. At the age of 5 years, he had a Lagrange discrepancy of about 4.5 centimeters. I did the first lengthening. I think this was also back in 2016 or something. And you can see this is the frame. K-wires, half pins, very classic frame. What we now do, if we do a lengthening like this, we transfix the fibula from medial with a screw, so that we don't need any K-wires anymore. Like in the proximal tibia, that makes walking and range of motion exercises much easier. But you can see here the nice lengthening and with a good result, and also the foot looked very nice. At the age of 9.5 years, he started to have some ankle pain with strenuous activity. And you can see now, because of the fusion and because of the deformity, this is a very bad position. So there is a translation problem. There is most likely like translation in the ankle joint during walking, and this is something the joint does not tolerate very well and usually gives pain. So it's at the same time it's really a flat top talus, so there's not a lot of congruency in this joint. So at that time I thought maybe doing an opening wedge osteotomy from posterior might reduce the slope and might make the joint a little bit more stable. And actually this did work. He was mostly pain-free in the years to follow. He's now 16 years, so about 7 years later. I actually saw him just last week or the week before, and now he does have some pain at the ankle joint again. So I think many of those, or some of those cases, they eventually end up like in an ankle fusion. But I think you can walk quite nicely with a fused ankle with a short foot. So maybe that's not such a bad thing. Now, do we always reconstruct? And that's the question. And so although I think reconstruction can be done successfully for most cases, so this is a case where the family decided against reconstruction, and I think that absolutely makes sense. It's very short, but then what's the treatment? Of course, it's some kind of amputation. But if you look at this, you have a very long problem list because the knee was not fully extendable. So also the foot, this is a problem here. So in this case, there is a lot of deformity you need to address. And in the end, I did a shortening and extension osteotomy of the distal femur. I did a posterior capsulotomy at the knee. I did an extension osteotomy at the distal tibia to make this more braceable, and I brought down the heel part, the skin of the heel underneath the stump to have a good stump for walking. But it's not only amputation, you need to go through all the problems still to make sure that this will be a functional situation afterwards. Now we talked about the ankle instability. The subtalar valgus and the ankle valgus we usually correct with the first surgery. You can do an osteotomy for coalitions, but of course you need to beware of recurrence during lengthening. So we always try to include the foot into our lengthenings. This is also a problem. You need to consider this if you do a nail lengthening. So the ankle joint is very sensitive, and you're very prone to get some equinus, but also some recurrent valgus if you do this. Sometimes, if there's no fusion, we can treat it a little bit like a flat foot deformity. As you can see in this case, there was just a calcaneocuboid fusion or coalition, but no other coalition within this foot, which shows a severe valgus deformity. So in this case, we decided to do a lengthening of the calcaneocuboid coalition, which actually worked quite nicely and was like a very, well, it basically was a lateral column lengthening, but without a calcaneocuboid joint being present. Now another thing you can do, and this is also very nicely described by Drew Paley, or was introduced by Drew Paley, and is described in this Journal of Children's Orthopedics, is a relative shortening of the tibia compared to the fibula to give it more stability and do a realignment at the same time. You need to cut the syndesmosis ligaments to succeed with this, and then you need to reconstruct it afterwards with a plate and with a tightrope. And yeah, this works quite nicely. I think there is maybe an age limit because the joints still need to adapt to this new situation. I'm not sure where is the age limit where adaptation is not possible. So sometimes the ankle can be the last step. So this was 2 children that came to us from, I think, Armenia, and this was in 2003. And they had a lot of reconstruction throughout the years, done very early by different people from our department. And so at the age of 23 years, I saw her again, and she had a leg length discrepancy of 2.6 centimeters and quite some problems with a procovatum deformity, some valgus, some shortening still, and an ankle problem with an instability and with also some pain. So I did like one last big step surgery for her, and breaching of the knee, I did a shortening of the tibia, shortening to get it shortened relative to the fibula, and at the same time a realignment, osteotomy, lengthening, and yeah, at the end she had an equal leg length, and if you look at the ankle joint, it was more stable, and also the fibula gave good stability. It took her some time. It took her about 3-4 months. She still had some ankle pain after 3-4 months. It was gone. I hope it stays like this. But that's what I said before. I'm not sure what is the age limit here, and if they do adapt, or if this will come back maybe later on and bite me again in form of like an early arthritis. I don't know. We'll see. In some cases, fusion is maybe the best solution. You can try to do something else, which I did in this case. In the end, sometimes you just have to fuse the calcaneus underneath the tibia in a way that is very plantigrade, shoeable, and makes it easy for the patient to walk and to use a shoe with a shoe modification. So in summary, it is a very complex pathology. I think the foot and ankle and the knee joint are the two more difficult things. I mean, the more and more of these cases we do, the more we realize the bone lengthening is definitely not the challenge. So it's everything else that goes around the bone that is difficult. But I think if this is also a work in progress. And I think with every year, with every experience we gain, and with every conference where we speak about our experience and learn new things, we get a little bit better. And yeah, I think that's my take-home message. Thank you.